last presentation of this morning is about tendinopathy of the canine shoulder. And there are a few important muscles and tendons in the region of the shoulder joint. So the shoulder is quite a simple joint. It's a ball and socket joint, we call. It contains two bones, the scapula and the humerus. And they are supported by muscles and tendons. So there are different muscles as we see here. Also several ligaments are present in this shoulder joint, not visible on these images. We will talk about that later. What is a ligament? A ligament is a fibrous band of tissue, actually holding bones together, connecting bones together, and also connecting cartilage at a joint. What is a ligament? That's what I just explained. What is a tendon? Is also a band of fibrous tissue, but that tendon is connecting muscle to bone. So that's the difference. We have the supraspinatus muscle, which we see here, with the origin, and importantly is insertion, really cranially, at the level of the humeral head, the greater tubercle, or tuberculum major. We have the intraspinatus, which also inserts at the greater tubercle, but a little bit more caudally than the first tendon. And then the teres minor, it's a quite small tendon and small muscle, also inserting at the great tubercle or more caudally. And then we have the biceps brachii, which originates from the supraglenoid tuberosity, or tuber supraglenoidalis, and that's the cranial distal point of the scapula, and then runs medially and distally to the ulnar and radial tuberosity. So this is a lateral view where we see nicely the tendons, and this is medially where we see the biceps tendon attaching here, and also here we have a detail about the medial glenohumeral ligaments and the transverse ligament which keeps or covers the biceps tendon. So the normal anatomy on an X-ray, if we imagine a little bit, according to the blue line, and the attachment here is the supraspinatus muscle and tendon, and a little bit more caudally is the infraspinatus, and the insertion a little bit more caudally than the supraspinatus. So we can't visualize soft tissue on an X-ray. A very sensitive technique for bony structures, but muscles, unfortunately, we cannot visualize. The supraspinatus enables extension of the shoulder joint, and the biceps tendon is responsible for extension of the shoulder joint in the standing animal. So that's the difference. Has a stabilizing function, the biceps, and takes care of the psychrogenicity of the shoulder and elbow joint. It has a quite strong ligament, the transverse ligament, which keeps the biceps tendon in its sulcus. So what about the ligaments, the glenohumeral ligaments? They are medial glenohumeral ligaments. They have a V shape, as we see here in this specimen. So this is the cavitum of the glenoid and the humeral head. And we can almost look through them. They seem quite thin. And we have the lateral one, which we don't see in this image. Arthroscopically, if we look inside the joint, we are able to see a part or a huge part of the medial part of the glenohumeral ligaments, which we see here. This is the distal part of the shoulder, of the shoulder joint. It is all the image, I mean the scapula, and this is the humeral head. Also, we are able to see the subscapularis, which runs intra-articularly. This is the tendinous part and the muscular part. In cases where a lesion in the shoulder is present, like biceps pathology or OCD, there is a general inflammation of the joint, and we see fibrillation of the glenohumeral ligaments. In this image, all the fibers, it's an inflamed joint. There's another primary pathology going on, and this is the subscapularis, and also with a lot of villi. It's also fibers due to the inflammation. Here we have a view in the glenoid cavitas of the scapula. This is lateral, medial, cranial, and caudal, and this is the medial glenohumeral ligament, and here we have the lateral. Now they are quite thin, as I said already, those ligaments, and there are colleagues in France and in the States who see a lot of patients suffering from glenohumeral ligament pathology and rupture and inflammation and things like that, and they see it in correlation with lameness. They talk about unstable shoulder joint. So we are not sure about that because we think those ligaments are reinforcements of the joint capsule. And the real stabilizing of the joint itself, it's performed by the tendons and the muscles. They are much stronger, much more developed, much more thicker. So that's a discussion and a debate on a lot of conferences. I have to admit we saw one of two cases really suffering from fibers and affection, which was more than in these cases, and maybe that the dog suffered due to a problem at the level of the ligaments. But it's not that we see a lot of dogs, and some colleagues do. So that's some debate which remains still these days. So what are the pathologies we see in the shoulder joint? And there are a lot, as we see OCD, trauma, tumors, of course, and specifically, which is important here, is the biceps tendon pathology, the tendinitis at different tendons, as we will talk more in detail immediately. But before that, it's important that the ossification centers that are present in every joint in the body in young animals, that we know when they fuse, when the growth plates fuse, which stage is normal in a lifetime of a dog and which stage is pathology. If we look to the supraglenoid tubercle, which is this area, it's a separate ossification center, and it fuses in between 3 to 7 months old. So it's difficult to say in that age whether there's an avulsion of that ossicle or the growth plate, or whether it's a normal stage. So what we also do in the clinic is always take bilateral radiographs. We take a radiograph of the lame side, but a control one of the same region of the other side, in order to compare and to be sure is something normal or abnormal. So this is a very young animal. This growth plate is also still open. So in this case, the left is a normal ossicle, not completely fused yet in this stage, and this is an avulsion of the tuberculum supraglenoidale in a young animal. So indeed, compare both sides, that's the easiest way to be sure. So in young animals, when the growth plates are not closed yet, it's a very fragile area, and the ligament or tendon that attaches there is usually stronger in that stage of the animal, the age and stage of the animal. So when something happens, the tendon will remain intact and will avulse the attachment, and that's something that we also can see in a hip joint, ligamentum teres, for example. So that's something that we have to know. So the biceps tendon attaches in this area. This is a case where the diagnosis was not made at the initial stage. Also a young animal, as we see, growth plates are still open. And this is a chronic case, so lesion is already there for some weeks in a young animal. The avulsion of the tubercle was not recognized in time, and then you see how ugly it will look then. So about the biceps tendon, what kind of pathology do we see? We see inflammation of the attachment of the biceps tendon. We see partial rupture or partial tear, and a complete rupture might occur. This is a case arthroscopically if we look with the scope in the cranial part of the joint, and here again you see the triangle, so meaning that we are looking to left, looking to the cranial side of the joint, and this is the biceps tendon with a lot of villi at the attachment. So there's always some villi visible in normal circumstances, but this is reddish and a huge amount of villi, meaning inflammation probably. So I already mentioned that on a radiograph we can't pick up any soft tissues. However, it's providing indirect information about soft tissues and articular soft tissues on a radiograph if we look well. So in this lateral view, we see the scapula and the cranial part of the humerus. This area, it's flattened. It's not rounded. It's normally also not completely rounded, but there's a roundish shape normally. And what we also pick up is this, some calcifications that should not be there. So, however, we don't really see soft tissue of the biceps. We know it's running there, causing secondary reactions in the bone, so we can be sure that something's wrong with the biceps tendon in that area. It's a little bit too bright here, but also in the sulcus, sometimes we pick up an inhomogeneous sclerotic pattern, meaning that something's wrong with the biceps. So again, here two examples, a normal one, and that's what I meant with the kind of round shape of the tuberculum supraglenoidale. If we look to this area of the humerus, normal density, homogeneous density, and this image, it's a little bit different. So there's a small tip and small sign of sclerosis in this area, and also something that we have to take in account is this line. This is the normal appearance, and it stops here, and if we look here, it's elongated and more sclerotic as it should be. This is the delineation of the tuberculum minor. And here we have the anatomic specimen to show you the area we are looking at. So we have a little bit superimposition. Here should be the greater tuberculum. This is the minor one with new bone formation and degeneration. Also here is the line of new bone formation present in this joint. If we compare this finding with CT findings, it's quite obvious. This is a transverse slice in this plane, where we have the great tuberculum, the small tubercle, and this is the area of the sulcus where the biceps is running, or the tendon, the attachment. And And it's very irregular, all kind of spikes and osteophytes hindering the biceps. So that's a sign of biceps pathology. Also, ultrasound is very useful to use in these cases, and it's not too difficult. This is a transverse plane of an ultrasound image, the tuberculous and minus and the sulcus in between. This is the biceps tendon, and here we see some osteophytes. We see some more ultrasound images immediately, and this is an arthroscopic image where it's obvious the inflammation at the level of the attachment of the biceps. So some other examples. This is also a case which is not normal. It's too sclerotic here, a little bit irregular. And here we have some sclerosis as well, and here it should be visible, not the nice homogeneity as we should expect. This is a Bernese mountain dog of 5 months and the same one at an older stage. And here we have the normal appearance of the delineation, and if you look very well, you see some kind of small opacity in that area, but at this stage it was not diagnosed, the pathology of the biceps yet. And in the older image of the same animal, it's obvious the irregular delineation, sclerosis, new bone formation, irregular sclerosis in this area. So what helps to even better visualize the soft tissues is performing an arthrogram. That's something we do a lot. I already showed you arthro-CT in the elbow joint, but in the shoulder, just fill the joint with contrast and take a radiograph. It's very useful. And we can see the filling of the joint space, the brightness with contrast. There are always pouches. They are filling with contrast as well. But in this area, the biceps tendon is running. The biceps itself we don't see, but nicely see the delineation as contrast is going along the sides of the biceps in the tendon sheet. So the attachment of the biceps is here, is a normal appearance and nicely homogeneous density of the delineation of contrast. We can do the same on CT and perform an arthrogram, and that's also very useful to delineate the attachment of the biceps tendon. In this case, and the next one, is pathology present at the level of the biceps. We see again the filling of the joint space. This is a bursa underneath the supraspinatus muscle. It's something which can be present. It's an normal anatomy, so not pathology, that the bursa is filling with contrast as well. If we look to the delineation of the biceps tendon, it's irregular, thin line of contrast also here, and we can't pick up the attachment anymore. It's a mess of contrast that we see here. So there's biceps pathology present at the level of the attachment of the biceps, and this means that there's swelling of the biceps. It's not been delineated. The contrast is not able to go very well along the biceps tendon itself, as we see here and here as well. There is almost no contrast going along the biceps tendon, and here there's no contrast in the sheet, meaning the tendon and the biceps is that swollen that the contrast is not able to go along. So also here we have an abnormal attachment, and here a mass of contrast representing abnormal attachment of the biceps tendon. So these arthrograms are always used practically in cases suspicious of OCD. It's very helpful to distinguish whether a flap is present there, yes or no, because then the contrast will run underneath the flap of the OCD, and then you can be sure it's in the OCD, I have to treat him. That's something aside, which is not the topic of today. Then about ultrasound, it's not that difficult to perform ultrasound of these cases. This is the direction of the probe, how we hold the probe, and this is the image we gain, the longitudinal image with the tuberculum supraglenoidale here. This is the humerus, and this is the attachment, here the attachment, and the delineation of the biceps tendon itself. That's a normal image. Here we have a different image where we pick up the biceps tendon, but we miss the nice attachment as it should be there. And beside that, there's a huge amount of fluid present along the biceps tendon. On the transverse images, if we hold the probe like this, we gain these images. We see the biceps in a transverse plane, which means we see the oval shape of the biceps, and often it will be also showing irregular echogenicity. Here it's quite homogeneous still. Which is remarkable here is the amount of fluids surrounding the biceps tendon. Okay, two examples with the corresponding ultrasound images. Again, a longitudinal image with the tuberculum and the humerus, and we see the calcification being present at the level of the attachment of the biceps tendon, and also the hypoechogenicity, meaning fluids, and the irregular echogenicity of the biceps tendon itself. In this case, again, we see also a gap here, like there's a partial tear or complete partial tear probably, huge amount of fluids surrounding, and also here. And arthrograms, just to show you again, this is a normal one. Nicely see the delineation of the biceps in a well delineated aspect. Normal attachment. These are air bubbles, so that's not abnormal. It might happen that some air is injected as well. And here again, where we have just a very discrete delineation, irregular blurring, and a missing of the attachment of the biceps tendon. So the biceps lesions, if we see effusion, that's not pathognomonic and not specific. So in cases that are overfilled, OCD cases as well, it will mean that in the area of the biceps there's too much fluid present as well. So we see in this image, for instance, a transverse one, a nice homogeneous biceps tendon, nice echogenicity surrounded by fluid, and this is a sagittal image, also fluid surrounding, so that's not specific. This is a pathologic case where the dog was suffering from right elbow, shoulder, limbs, I'm sorry, the right one and the left. Again, the left a normal, homogeneous echogenicity, just the normal amount of fluid surrounding. This one, huge amount of fluid, and we can't pick up the biceps tendon anymore. The sagittal images, where we immediately see the homogeneous aspect of the left side. This is the thickness being measured, and the pathologic side, where there is an increase in thickness and also a loss of normal echogenicity. And also in the sagittal plane, where we have the irregular delineation of the scapula, a huge amount of fluid, and also irregular echogenicity, showing that there is pathology in this case here, how it should be the normal attachment. And this was a case of a partial tear at the level of the attachment of the biceps to the tuberculum supraglenoidale. Okay, we go to the supraspinatus muscle. Also an important one, what kind of pathology we see here. Often it starts with an acute lesion, which has not been diagnosed. It becomes a chronic lesion. And that goes often together with the development of opacities at the level of the tendon. And those opacities are the ones we pick up on a radiograph. But even at that stage, when we pick up calcifications in the tendon, it's not sure that we are dealing with a clinical case. So that's something that's often hard to distinguish. Is there really supraspinatus pathology still going on? Or is this an incidental finding? Or are these opacities pushing on the biceps tendon? It might be that they hinder the biceps tendon. So that's something that's important to distinguish. So also an arthrogram can be helpful in these cases. Here we have the nice delineation of the biceps, as it should be, and these are the ossicles, development of calcification ossicles after a probable supraspinatus problem. So in this case, we can be sure that the ossicles are not hindering the biceps tendon. There is no loss of contrast, it's a perfect normal biceps delineation. In cases we want to be sure whether it are calcifications or not, because here it's been superimposed on the head of the radius, humerus, I'm so sorry. We can rotate the joint and take a kind of an oblique view in order to visualize well, without superimposition, the ossicles that usually are nicely rounded. So another case, again with the ossicles, and if we take CT of these cases, we can see, and most cases when they are nicely rounded, they are not hindering anything, but still on this image you can see very well, as this is the sulcus where the biceps tendon is running, it's really close by, often very close by to the biceps tendon itself. Helpful here as well is the arthrograms, as I just showed you on the radiograph, but also arthrography on CT is helpful, where we see the biceps tendon nicely surrounded by contrast. So it's an intra-articular CT, transverse slice. There's no swelling of the biceps tendon, nice delineation, and we see not even contacting the contrast, the ossicles that are present. This is an ultrasound image, also of an ossicle. This is the attachment of the biceps, the biceps tendon, or at least a part of the scapula, where we see the calcification within the tendon. So, technique with it, which is very sensitive to visualize soft tissues, is MR. You can nicely visualize tendons and muscles in detail, and if there are signal changes on some sequences, you can be sure that pathology is going on. These are two sagittal images of the shoulder joint, and here the arrow is pointing at the hypodense area on this STIR image. This is a supraspinatus muscle. This is a T2 image where the hypodense spot is bright. This means that there is a fat content present in this area, in the supraspinatus muscle, just above the tendon. It is in this T2 image. This is blocking out fat, this sequence, so it means that's why it's hypodense. What often occurs is that a tear in the supraspinatus tendon and muscle will be replaced by fat content, and that's what we pick up on these images. These are transverse images of the same shoulder joint at the level of the head of the humerus, and we see this huge soft tissue circular structure. This is the damaged or affected inflamed tendon of the supraspinatus, and it's causing compression on the biceps tendon. This is the sulcus where the biceps is running, and this small dark spot is the biceps tendon being pushed away by the swelling and inflammation of the supraspinatus. Also here on this T1 image, maybe better visible, the bright thickness, irregular signal of the supraspinatus, and the gray spot here is the biceps being pushed away and probably hindering and causing problems at the level of the biceps as well. So, another example with a huge reaction, inflammation at the level of the tendon of the supraspinatus. Here is the attachment of the biceps at the level of the tuberculum supraglenoidale, and we see an irregular signal at the level of the biceps as well. More clear on this image, where we see impingement, we call it, that the supraspinatus is really pushing on the biceps tendon and might hinder secondary the biceps tendon. But as I said, ultrasound is very sensitive to visualize soft tissues, and MR as well. What about the infraspinatus? It's quite a smaller, more caudally localized muscle, and lesions at the muscles and tendons of the shoulder often cause atrophy, muscle atrophy at the level of the lame side, at the level, of course, where the muscles or tendons are affected. Also, in these cases, pathology and tear at the level of the infraspinatus will cause muscle atrophy. And this kind of lesions is that we see, the contracture, is a result of a chronic tear in this infraspinatus muscle and tendon. And we see that in hunting dogs. Dogs that are overloaded, so that are trained to work a lot, that we see initially, as it's been described in literature, the tearing of the muscle resulting, and then we have a problem of a contracture. And what means the contracture is that the dog is not able to hold his limb anymore, and